Hi, it's Sarah. Here we go, your last two theorists. So both of these are mid-range theories. So we'll look at Kolkaba and the comfort care theory and Locsin's theory in terms of technology. So again, we're just going to look at both of these particular theories and look at their application to nursing practice. So just as a reminder, mid-range theories are a little bit more narrow in scope and offer a lower level of abstraction rather than the grand theories such as Watson's theory of human caring and Parse's theory of human becoming. So both of these here are mid-range theories. So for Catherine Kolkaba, and now the website that's there posted is actually quite good. So you might want to take a cruise through that just to get yourselves a little bit more grounded in her particular theory. So for her, again, her notion was that comfort as a key component within nursing practice is really quite a complex concept. So for her, it was talks about, not only how to care, but also how to be a nurse. And for her, it was really important to look at the whole notion of really looking at what comfort means, and that it really is quite a very complex concept. So again, when we think about, just as a moment of reflection, when you hear the word comfort, what does that mean for us as nurses? So whether a patient is comfortable, is experiencing discomfort, what exactly does that mean? And what does it look like when a patient is at ease or is comfortable? So again, a very complex concept that we use quite a bit in our practice. So she talked about that comfort, the need for comfort is very basic. So even think about Maslow's hierarchy. We experience comfort holistically, so it's not just a physical attribute, but again, you'll start to see in her taxonomic structure the various elements that she sees in terms of comfort. Self-comforting measures can be healthy or unhealthy. So if you think about, what are some of the unhealthy self-comforting measures that people engage in? Smoking could be one, drinking could be one. Those of us that I'm guilty of, you have our comfort foods that we go to. So even thinking about comforting measures being healthy or unhealthy, and then the whole notion of enhanced comfort obviously can lead to greater productivity. And again, just how complex the word comfort is as a noun, an adjective, and actually an outcome. And for us, it's an outcome of our care. So they look at this now, the whole notion about, this connection to health, that really if somebody is comfortable physically, emotionally, mentally, spiritually, that in itself is a definition of health, and a definition of what it means to be well. So for her, these are the key components. So for Kolkaba, she identifies 3 stages of comfort: relief, ease, and transcendence. And you can almost think of them truly as being stages in progression. So relief is about having your specific comfort needs met. Ease then is having a state of calm or contentedness. And then transcendence, who does that remind you of? That's a Parsi, is about rising above problems or pain. So again, moving beyond. So think about these as stages. So relief, think about in terms of, pain management, having my specific comfort needs met. If that's been achieved, then I can move on to, or perhaps achieve, a sense of ease, calmness, and contentment. If that has been achieved, then I can actually look at achieving that sense of transcendence. So moving above and beyond the here and now and kind of looking at what are the future possibilities. So for her, 3 stages of comfort: relief, ease, and transcendence. Within those 3 areas, she also sees comforts within 4 contexts. So again, much more beyond just the physical, but looking at psycho-spiritual, environmental, and socio-cultural. So again, the notion of comfort itself as being really quite complex. So as a result of that, she developed what she refers to as this taxonomic structure. So again, for Kolkaba, it is comfort. It's the 3 stages of comfort. So relief, ease, and transcendence. The 4 different components of comfort in terms of physical, psycho-spiritual, environmental, and looking at sociocultural. And then here is about now looking at comfort within this taxonomic structure, recognizing that individuals can achieve comfort or experience comfort relief, and relief can come in the form of physical, psychospiritual, environmental, sociocultural. Same thing with ease. Same thing with transcendence. So again, looking at the complexity from her perspective in terms of the whole area of comfort, and we'll walk through an example of this in a second. So the taxonomic structure, the purpose is really to determine the existence or the extent of unmet comfort needs, and for then the ability to look at it from an assessment perspective to identify what are the bundles of comforting interventions that are actually required, and looking at it really from a holistic perspective. So again, if you look at this, just to go back, this is a way of assessing comfort for an individual. What's being met, perhaps what's being unmet, and then as a result of that, what are going to be my interventions as a nurse. So one of the things that I posted in the shell for you is this comfort questionnaire. So this is what she developed as a way of assessing or determining patients' comfort. So for those of you that are listening to this here, take a look at that comfort questionnaire. And what I'll challenge you to do is, here you can just see just a few of the questions. I can't even remember, I think there's 20, 30 questions on the questionnaire or items. And then just look at that and see if you could actually, based on the item, where might you pop that into the taxonomic structure? So if you look at things in terms of my body is relaxed right now, that could be relief physical, it could be ease physical, I have enough privacy, that's environmental, I feel confident, socio-spiritual. So just as a little laugh for yourself, go through the items, because again, for her, this is her taxonomic structure is about how do we assess for comfort. And then these are the items that she built in terms of a questionnaire that are reflective of her theory to get a sense of, based on the client's response to these questions, to determine again what comfort needs are being met and where are the areas that are being unmet. So I'm not suggesting that this is how we would assess comfort in our clients, but if you look at the items, you can actually then kind of get a sense of how you might incorporate these types of questions into your own practice with your patients. This is just, I'm going to skip over this, but again, if you go to the website, there's a nice little video here about how she actually explains her structure. So here are the different areas. So obviously the physical comfort we know about. So the comfort needs of the patients in terms of physical is really about having those physiological needs met in terms of very specific needs. And then again, those can be, physical needs, psychosocial. So psychospiritual comfort speaks about anxiety, fear, what the meaning of illness has for the individual, their life review. Who does that sound like? So again, you can see where mid-range theories are sometimes very reflective of larger grand theorists. So again, spiritual needs, where do they get their sources of strength, et cetera, et cetera. Psychocultural comfort can have to do with things such as, their financial issues, what information do they need in terms of effective discharge planning and health teaching, traditions in terms of what and how we incorporate that into practice, and then looking at the notion about even continuity of care provides sociocultural comfort. Think about that as a patient. How do we provide comfort through things such as just the nursing assignments, recognizing it's comfortable for me as a patient to know that I'm going to have the same care provider versus this constant stream of strangers in my life. Environmental comfort in terms of literally, this is the room. So who does that remind you of? Nightingale. Looking at the whole notion of, so you can see this now with all the new hospitals, it's all private rooms. They maybe will have one, I'll say 4-bed ward room per unit now, but they're all private rooms. Do we have space for family? Meals, this whole piece, right? So even just looking at the comfort needs and how we actually provide that within the environment. And then this is the whole conceptual framework for comfort theory. It looks busy, but just hang on. It's not really that complicated once you start to break it down. So it's really about, these are the needs of the patient or the family. We as the nurse then identify, looking at those comforting interventions based on our assessment using that taxonomic structure. So this is our role in terms of what are the comforting interventions that can help to address their needs. The intervening variables that they refer to in the text are things such as what might be confounding variables in terms of here's my intervention, whether or not the patient experiences comfort or not. So these intervening variables are things such as the age of the client, their previous experiences, culture, some of these things that can almost act as a filter, if you will. And then looking at the goal here is that the client then experiences enhanced comfort. The notion is if they are experiencing enhanced comfort, relief, ease, or transcendence, they are then placed in a position of being able to engage in health-seeking behaviors. So, and health-seeking behaviors can be internal behaviors, such as even just restoration and healing, external behaviors in terms of other motivating factors, in terms of external comfort, but also health-seeking behaviors can actually be looking at the whole notion of being in a state of grace, for the lack of a better word, about achieving a peaceful death. Institutional integrity really speaks to an organizational integrity. Your text talks about, organizations, but also communities as well. That really, what this is about, really, it's about looking at supporting nurses through best practices and best policies to engage in really excellent patient care. So institutional integrity really has to speak to all about the practice setting, in terms of how does the practice setting actually support nursing practice in achieving comfort for clients. So again, although this structure looks a little busy, it's not all that complicated. The patient has needs. Based on our assessment, we provide those bundles, if you will, of comforting interventions based on perhaps some intervening variables such as age, culture, or past experiences will determine the degree of comfort that the patient experiences. Based on that, it'll determine the degree to which they will engage in health-seeking behaviors. So these are, again, her entire conceptual framework in terms of the whole notion about comfort theory. In terms of those comforting interventions that were just mentioned on the previous slide, she speaks about in terms of 3 different categories. So think about this from nursing practice. And again, I'm going to draw your attention here to the whole novice to expert component as well. So obviously certain comforting interventions, technical, what we do really, really well, specified by other discipline or nursing protocols, medications, treatment, monitoring schedules, things of that nature. So kind of the core aspects of a lot of what we do in terms of nursing practice. Coaching as another comforting intervention, which is really about active listening, good patient education, advocacy, reassurance, really though that supportive role that we have, that we do really, really quite well. And then again, if you think about this in terms of an additional area, what she refers to as comfort food for the soul. So really looking at a holistic, more time consuming interventions, but they're really not. But these are the types of things that we've kind of, I don't want to say gotten away from. Providing that patient with that good massage, ensuring, encouraging that they go out for a walk, or we go out for a walk with them, kind of doing, I'll say, a little above and beyond, making arrangements for family to stay in the room, even looking at what it is that we're doing in terms of visiting hours. So these are the types of interventions, comforting interventions. So technical, coaching, and comfort food for the soul. And I'll challenge you to think about the different types of comfort where she talked about before in terms of relief, ease, and transcendence. And I would say that this is relief, this is ease, this is transcendence. And again, looking at from a novice to expert capacity in terms of these are the types of things you could even say, novices have a tendency to focus on this because I'm a novice, so I've got, I can only handle so much. But as I grow in my experience as a nurse, these are the types of things that we really see from nurses, to be able to move beyond just the technical, provide those additional supportive components, but really looking at that patient from a holistic perspective and kind of going above and beyond. So here's just an example about the application of comfort. So you've got a 74-year-old client still in his home with a 70-year-old wife. Mr. Green has had some weight loss with increased appetite, diminished vision. His wife is extremely anxious. At the physical exam, they're both present. And as a result, now Mr. Green has been diagnosed with type 2 diabetes. So again, about using the grid, this is what the grid would look like in action in terms of your assessment of Mr. and Mrs. Green in all actuality. So physical, we need to address the issues about hyperglycemia, his weight loss, diminished vision. Right now they're anxious. New diagnosis. How are we going to manage this? Sociocultural. They need to understand in terms of what this means in terms of diet and any other sequelae. What is this going to do in terms of any financial issues for us? Anxiety of the wife, her need for reassurance, and how this is going to impact their practice, and the whole notion about even environmental, just navigating the waiting room and going for further appointments, et cetera, et cetera. If you look at, so that's the immediate. This is almost the immediate things that need to be addressed. But our longer term goals is to look at the notion of ease or maintenance. So this is where they are now. I want to, our goals are to look at normal blood sugars, doing some, increasing the weight, making sure that there's good skin integrity, making sure that they're confident and adhered to the plan of care. In order to do that, they need to understand what that plan of care is, what type of services are available to them. And even, for us, this is almost at organizational integrity in terms of, how is it that we create a welcoming environment. To the point of really long-term goal, we'd like to see transcendence, that he really wants to adhere to this, sees this as part of his new life and his new routine, accepting it, and really engaging in those really effective health-seeking behaviors in terms of maintaining healthy weight, good blood sugar, et cetera, but does no longer see it as a problem, but is just part of the overall component. So this is, again, an example where you apply that taxonomic structure. So here's the here and now. This is what I'm going to assess for now. These are my, I'll say, intermediate and long-term goals for Mr. and Mrs. Green. But again, so this is what comfort looks like. From Kolkaba's perspective, for both the client and his wife, immediate, and we kind of look at intermediate and longer term goals. So this is the case study that is available in your text. So what I'll suggest that you do, take that case study of Susan that's in your text and review that, and then look at that in terms of, again, applying the taxonomic structure. So work through that and see, again, what you would identify as some of those immediate care needs. So relief, what's the immediate relief that Susan needs? What would be aspects about ease and transcendence? So again, take a look at that case study, and just as we walked through with Mr. and Mrs. Green, look at how you would actually apply Kolkaba's comfort theory to Susan. So again, really identify not only, again, your overall assessment in terms of relief, ease, and transcendence, but then on top of that, what would be the nursing comforting interventions that you would apply? So what would be the aspects with regards to technical, coaching, and that comfort food for the soul? So here's the nursing meta paradigm for Kolkaba. Again, so she really looks at the needs in terms of the person is an individual, family, or community that's in need of health care. So really looking at that not only from primary care, but also preventative care. The optimal function is really, in terms of health, is facilitated by enhanced comfort. The environment, because it's a key component within her taxonomic structures, really looks at how does environment actually affect comfort. And for her, nursing is the intentional assessment of comfort needs, designing of comfort measures, and ongoing reassessment of comfort after the implementation of those comfort levels. So there's Kolkaba. And then now we'll just go on and look at our last theorist with Kolkaba Locsin. So here's our last theorist here. So Kolkaba Locsin really looked at the whole notion of technological competencies of caring and nursing theory. And I really think that this is a really interesting theory, recognizing the complexities of technology in healthcare and how that's actually even just going to increase more and more. So he's got a really interesting spin on this. So for technological competence as caring and nursing, it's the process of knowing individuals as whole while frequently engaging technology advancements. And again, you can see that the theory is really relatively new. It's not even 10 years old, but I think it's really about this whole notion about knowing individuals as whole, but still while engaging in technology. So the whole notion about technology and caring. So this is right out of your text. The ultimate purpose of technological competency is to acknowledge that the purpose is the focus of nursing, and that the various technologies can and should be used it's really here in the service of knowing the patient. So that technology doesn't replace care. What technology does, it helps us to really know the patient. That's what technology is really for. So technology is used to understand the uniqueness and individuality of the person as a human who continuously unfolds and who therefore requires continuous knowing. Who does that sound like? Sounds a little like Percy to me. Again, recognizing that we are continuously ever, indivisible, unpredictable. Technology allows nurses to know about the person only as much as the person permits the nurse to know. I'll take you back to Parsi. So the whole notion about rhythmicity, concealing, revealing, that the paradox is within those different components. Locsin believes that we know the person through technological competence, which is about really assist the nurse in acknowledging the person as a focus of nursing. So the person is the focus, not the technology. That's his biggest thing. Using technology to complement or assist the nurse in knowing the patient in the moment. So how do we utilize that technology, whether it's an ECG machine, this is really more so when you get into ICU where the person is plugged into just about everything. He believes also it's not only just about technological competence, but about caring, authentically knowing the person in the moment. Who does that sound like? To the extent to which they wish to be known. So that technology doesn't replace that interaction with the patient. And also human beings as persons, knowing the patient in the moment as whole and complete persons despite their conditions. So again, not labeling the individual just really by their diagnostic state, but really looking at that whole component in terms of what they look like. The key phrases from his theory is, again, the nurse can know the person fully only in that particular moment because, as Parsi would say, that Locsin builds upon, we are ever-changing, unpredictable, indivisible. It is not entirely possible for the nurse to fully know another human being except in the moment, and only if the person allows the nurse. So despite technology, it is still really about, as the patient, what it is that I fully wish to disclose and how that comes into play. The expectation is that the nurse will use multiple ways of knowing competently in using technologies in order to fully know the other person. So still using our empirical knowledge, but also looking at the notion of ethical, aesthetic, and all the other ways of knowing in terms of how we bring all those pieces together when using technology. So it's not about technology driving care, but it's about using technology as a way of really fully knowing the whole person. So this is the framework, and I just want you to take a look at this in terms of his particular framework. But who else do you see sitting in this particular framework? So I already identified the multiple ways of knowing. But look at this. Call and response. Gee whiz, I wonder who that sounds like as well. So really recognizing in terms of how do we look at all the various components in terms of really knowing the person. Knowing the person and is really what the practice of nursing is about. But how do we use technology to support us in this? So the whole notion about what or who is a person, technology is used to know who is the person rather than what is the person. What is the person is about the empirical facts, diagnosis, blood pressure, blah, 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 blah. But this notion about who is the person is this unpredictable, irreducible person who is more and different than the sum of his or her empirical parts. So again, really drawing from, you can hear Watson and Parsi within this. So really looking at, again, not allowing technology to take the person out of the care, and actually start to be the driver of the care, but recognizing that technology is there to help us to know the full person. So the framework is really looking at this whole notion that technology is used to magnify the aspect of the person, that the person is living, dynamic, and cannot be predicted. So again, recognizing that we cannot let technology remove our focus on the person. So it's about knowing, designing. So both the nurse and the patient come together and make a mutual plan of care, looking at, again, what is responsive to that particular patient's needs. So we have knowing, designing, and then participation and appreciation. Again, looking at the notion about implementation and evaluation. So once we've designed the care, we implement, and we're looking at in terms of is it effective, but that continual process of that ebb and flow. So again, this notion of rhythmicity and verifying that knowledge. So again, really verifying that, again, we acknowledge that people are ever changing and there's a dynamic process in knowing, and how do we again engage in that particular process. So Locsin recognizes, so this is one of those, unbelievable pictures, and if you can see in here, there's a little tiny person in there, but this is how wonky, as you know, ICU can get. So he acknowledges the need for technological expertise, but it is a part recognizing that he feels strongly that technology is part of caring. And we really have to look at this harmonious coexistence between technological competence, knowing how to work all this stuff, but yet caring. And that they do actually complement one another versus all of this getting in the way of caring for that little tiny person that's at the end result of all that technology. So looking at the basic principles is that, short, sweet, and to the point, he feels that technology really can help to bring us closer to the patient. But we want to make sure that, unfortunately, that technology can also increase the gap. And that's where the concerns are, is that we really have to look at this notion of this harmonious coexistence between technology and caring. This is the meta paradigm for Locsin in terms of, again, you can start to see some similarities from some of our grand theorists. He sees the person as unpredictable, very dynamic, and looking at, again, that holistic person. Health is experienced or expressed by the one being cared for, that we don't fix anybody or try to make them whole again. Again, thinking about of our grand theorists. This is about where technology is used in terms of the environment. And if you start to think about the whole notion of digital health and everything that's really coming down the road, this is not just about the ICU. This is about all the different types of technology. Think about the application of this theory with an expanding, I'll say, market and application for telepractice, where I'm the nurse sitting in Ontario, and you're my patient in Florida. Or I'm the nurse sitting in Toronto and you're the patient up in Sudbury or whatever. So again, we have to look at, the expanding use of technology and how do we create that harmonious coexistence. So that's our last theorist. So congratulations, you're done with those. Sorry, this is a little long. We're running almost about a half an hour, but I hope you found this helpful. And if you have any questions, just post them in the discussion board, okay? Take care. Bye.